This is the Whole Care Network. Helping you tell your story one podcast at a time. Content presented in the following podcast is for information purposes only. Views and opinions expressed in this podcast are solely those of the host and guest and may not represent the views and opinions of the Whole Care Network. Always consult with your physician for any medical advice, and always consult with your attorney for any legal advice. And thank you for listening to the Whole Care Network.
So I really do believe that part of showing up for patients, so part of being a great nurse for seriously ill people or a great doctor for seriously ill people is filling up your own cup first. It's part of your job, because if you don't do that, you will not be as good for your patients, and you shouldn't do anything that makes you be not as good for your patients.
Today's guest is Integrative Palliative Physician Dr. Delia Chiaramonte, host of the Integrative Palliative Podcast. Whether you're a family caregiver or an end-of-life professional, the Heart of Hospice podcast is here to enhance your hospice experience by connecting you with information you can use about end-of-life care.
The sponsor for this week's episode is Barbara Carnes Books, featuring the work of award-winning hospice RN educator Barbara Carnes. BK Books is proud to offer the End-of-Life Guidelines series, a compilation of 5 essential education booklets designed to support those caring for terminally ill loved ones. Visit bkbooks.com today to order the End-of-Life Guidelines series to support your journey of compassionate caregiving. This episode is sponsored by Odonata Care, creators of the Hospice Care Plan. Hospice agencies and end-of-life doulas are now using the Hospice Care Plan booklet to support their patients and caregivers. It's become a trusted resource in the end-of-life community, helping to educate and equip caregivers. Visit thehospicecareplan.com today to purchase the Hospice Care Plan booklet.
Fantastic guest, fantastic conversation today. We were just in a mind meld. If I was a Trekkie, I would call it a mind meld. Dr. Delia Chiaramonte is my guest today. She is an integrative palliative medicine physician and a caregiver coach. She's the founder of the Integrative Palliative Institute and host of the Integrative Palliative Podcast. She's also an adjunct assistant professor at the University of Maryland. She's a writer, and she's been voted a top doctor by her physician peers. She has a new book out, Coping Courageously, a heart-centered guide for navigating a loved one's illness without losing yourself. You can already tell there's a lot of wisdom and needed guidance in a book with a title like that. You can find more information about Delia's Courageous Caregiver program at caregivingishard.com, and her website is integrativepalliative.com. And if you're not sure how to spell all that, check the show notes. I'll have links there for you to go straight to the website. Dr. C, as she's known, believes that it's never too early for palliative care. And we're going to be talking about why in the interview, about why she believes that. She did a lot of teaching about palliative care that really cleared it up for me even, and I think it'll be great for you to hear it. But the main goal that she emphasizes is that palliative care is to reduce suffering of mind, body, or spirit. And she describes the work of an integrative palliative physician in great detail. She talks about 3 buckets that patients need help with and how palliative care physicians work to help them with those 3 areas. We kind of got off on a soapbox, me and her both, about our pet peeves when a physician says, "There's nothing else we can do for you." Oh my gosh, we've got to stop saying that. She talks about having these hard conversations with patients. They are difficult for clinicians. We need practice, we need training, and we need guidance on it. She said one of the best places you can start is with a dignity question. What do I need to know about you as a person to take the best care of you? What a great way to say, how can I take care of you as a human? Delia also shares that the self-care practice of clinicians is part of their job, and she's going to tell you why she says that. So her website is integrativepalliative.com. Check the show notes. Watch for her new book, Get a Copy for Yourself, Coping Courageously, a Heart-Centered Guide for Navigating a Loved One's Illness Without Losing Yourself. If you are a clinician caring for anybody, regardless of what stage of life they happen to be in or stage of health they happen to be in, you're going to need this interview. So here's my conversation with Dr. Delia Chiaramonte. Delia, welcome to the Heart of Hospice podcast.
Thank you so much for having me.
It's so easy to interview another podcaster. I feel like I'm not going to have to do any work today. Thank you for that.
You bet.
It really does make it easier. You know, you're used to the recording format. You're not scared of the mic. So we're going to be able to jump right in. I do want to ask you an icebreaker question that I didn't share with you beforehand. Just a little sneaky. If you were in charge, queen of the world, what 3 people would you choose to get advice from? Who would be your advisors?
Who would be my advisors if I were queen of the world? Michelle Obama, for sure. Mm-hmm. My daughters. I have 2 really wise, heart-centered daughters.
Nice.
I would let them share. They're one.
Good.
Let's say Nelson Mandela, because Nelson Mandela was really brutalized and kept a really open heart. And I would want someone to teach me how to do that if things got tough.
Oh, I would vote for you if those are your advisors. That's awesome. Oh, I'm so glad I asked you that question. That's great. Well, we are going to jump in because you're going to be educating not only my listeners, but you're going to be educating me as well today. We are going to be talking about integrative palliative physicians, which is the work that you do. So just jump right in and tell me what an integrative palliative physician does. What is your work?
Thank you for that question, because this is really my passion, is to educate people about this exact thing. So I'll tell you overall what it is, but then if it's okay with you, I'd love to break it into the pieces so I can make it really clear. Is that okay?
Yes, that's perfect.
So big picture, integrative palliative care is whole person care for families who are facing serious illness using all of the tools that work. And so let me tell you what I mean by that. I think the easiest way to do this is to break it up into what is integrative medicine and what is palliative medicine or palliative care.
Okay.
So integrative medicine is a whole person specialty. So the goal is to see the whole person, not the disease, but the whole person, and to use tools that people may not have learned about in school, in medical school or nursing school. So not just medicines and surgery and procedures, but also things like acupuncture or massage or meditation. Evidence supported, so not just things for the heck of things, but other ways of healing people besides just pills. So that's the idea of integrative medicine. It tends, though, mostly to be focused sort of on the healthier side of people, prevention of disease, people who are generally well. Now, to take palliative care, what is palliative care? Many people mistakenly think that palliative care is end-of-life care, but it is not exclusively end-of-life care. Palliative care is the care of people who have serious illness focused on reducing their suffering. So that could be physical suffering like pain or nausea or constipation, emotional suffering, existential or spiritual suffering. So while the oncologist is working on the cancer, the palliative care doctor is working on reducing your nausea, reducing your fatigue, reducing your pain, treating your anxiety, so reducing suffering. So when you put them together, integrative palliative care is essentially whole person care for a patient and family who's facing a serious illness, just with a bigger toolbox. So yes, medicines, yes, procedures, yes, surgery, but also acupuncture to help with pain, acupuncture to help with depression or anxiety, mind-body tools to help with pain or anxiety or sleep, massage to help with pain, et cetera, et cetera. So it's just a way bigger toolbox to help reduce people's suffering.
That's a perfect explanation. I can see it completely. I love the idea of integrating all these different modalities for all the different parts of a human, mind, body, spirit. That's a wonderful explanation. People really do get hung up on palliative care being end-of-life care. It's a little bit confusing because they are so attached. All hospice care contains palliative care, but not all palliative care is hospice.
Correct.
Yeah, I think that's where people get nervous. You talk about bringing in a palliative care team, and they think you're talking about death and dying.
Exactly. And so as a practicing palliative care doctor, when I was in the hospital, we hated to hear this, but we heard it all the time. Oh, it's too early. For this person who's sick and in the hospital, it's too early for palliative care. But the crazy thing is it's almost never too early for palliative care, because palliative care really is appropriate at diagnosis of a serious illness, even if you're hoping to get cured. So if you got diagnosed with a cancer, stage 3 cancer, say, and you're hoping to be cured or have 15 years without cancer, palliative care is still appropriate because our goal is to reduce symptoms, reduce suffering. So if you're getting chemo, you probably aren't feeling great. You might be tired. You might be nauseous. If you have cancer and you're anxious or you're feeling depressed or your family's having trouble connecting and talking about it, all that stuff is all what palliative care clinicians do. So from our perspective, since we think it's crazy that people don't want us to come because we're all about making you feel better, right? Some doctors make you feel worse. Oncologists are wonderful and God bless them. And, if I get cancer, I want one. But right. Their job is not to make you feel better, right? In the beginning, they make you feel worse. They sent you to chemo. They sent you for surgery. They sent you for radiation. You feel worse. So they're working on the cancer, but we're working on the person and the family. And that's actually one of the things I love about palliative care is that the unit of care is the person plus the family. Whereas in most of medicine, it's the patient. And then, we care about the family, sure, but our unit of care is the patient. Palliative care is the only specialty that I know of where the literal unit of care is the patient plus the family, because we know that illness is not just about one person. When illness hits a family, it hits the whole family. And so that's our goal, is to reduce suffering in everybody in the family. And family is whoever the patient says is family. Right. So that could be your best friend. It could be your neighbor, whoever is important to you, that's your family.
Yeah, blood family or chosen family.
Exactly.
It's interesting. I've never heard what you're saying about people thinking that, it's too early for palliative care, because we get that a lot in hospice, right? Which is the reason folks think, hospice is for when you have one foot in the grave and one foot on the banana peel, and mom's right. Within a day, a couple of days or a week of dying. And that's why our length of stay is so short. And right. Hospice is underutilized. We know that, especially for certain diagnoses like dementia, because it's really hard to figure out where they are if they're clinically appropriate for hospice. But palliative medicine must be the same way. A lot of misconception about what you guys do. A lot of ignorance, and that's not a disrespectful term, but a lot of ignorance on the part of the workers in other healthcare silos.
100%, including physicians who interact with palliative care doctors, hospitalists, ICU doctors, also don't know. They also confuse hospice and palliative care and think that it's time to call palliative care when they're about to call the hospice, which of course is not at all true. Anybody with a serious illness who's having any suffering is appropriate for palliative care. So I tend to think of it as we help people with 3 separate buckets. The first bucket is symptoms. So pain, nausea, constipation, insomnia, depression, etc. Symptoms. The second bucket is coping. So if you have a serious illness, you've got stuff to cope with, right? You have to deal with the doctors. You have to deal with your own feelings. Maybe your body looks different. Maybe your identity is different because you can't do stuff anymore. Maybe your family's in conflict. So symptoms is one bucket, coping is one bucket, and then the third bucket is decisions, medical decisions. And sometimes that means, do you want intubation or not? But that's not the only decisions. It could be, do I want to do chemo or not? Do I want to get a second opinion or not? Do I want to go to a different hospital or not? Do we want to have mom live in a facility or not? So there's lots of decisions to make. So if you have a serious illness, do you have symptoms? Probably. Do you have coping things? Probably. And do you have along the way decisions to make? Probably. All of that stuff is what palliative care helps with.
Yeah, that all makes complete sense. Do you find that when an advanced care plan conversation needs to be had, that the knee-jerk reaction is, oh, let's call the palliative care team to have these conversations? Because we know that most physicians are not comfortable, nor do they have time, nor do they have training to be able to have really robust, compassionate, knowledgeable conversations about advanced care planning.
Yeah, I think you are exactly right. And I have seen some difference of opinion in the palliative care communities that I've worked with around this issue. Some people feel like doctors should be having their own conversations. We are not the only ones who can have this conversation, which I understand. But my feeling really is, hey, if you want me to help you with that because I feel comfortable with it, I'm happy to help you with that. So I think the ideal scenario is they sit in so that they can watch how it's done skillfully so that next time they feel more comfortable doing it themselves. But it never bothered me when doctors call for our help with these conversations because they're important and it's important to do them well. And sometimes if you don't know how to do it, you do things like, well, looks like your chemo's not working, so I think it's time for hospice, so we're going to call them, okay? And that is not a helpful conversation.
That is not advanced care planning. No.
But I have heard conversations that sound sort of like that.
Sure.
Or they'll say, do you want us to do everything? And the person says, well, yeah. And then that counts as an advanced care discussion. And that's, of course, absurd. So I think it's really important to do it skillfully. But here's one thing. People have said to me, oh, you're just so good at that. Like it's somehow a natural skill. No, you just learn how to do it. If you can learn how to do surgery, you can learn how to have a good advanced care planning conversation.
But you find ways to educate yourself, looking at what other people are doing, finding the resources that are appropriate, because I think advanced care planning is very individualized. Some people want to talk about spiritual needs, spiritual care directives. Some people want to inject a little bit of humor. Some people want to talk about including all of their family in their decisions. Other people want to do that in a very private, it's an independent decision. So I think that being trained in how to do it is super important.
Agreed.
But if you have a patient on the floor in the hospital and say you have a team of, I'm being generous on staffing, say 6 nurses on shift. Yeah, I know. That was hilarious. When you have a patient that needs an IV, you're going to call on the nurse that's the best stick, as we call them, the person who's best at IVs. So it makes sense that you want somebody who's really skilled to have these advanced care plan conversations. However, what I believe as a clinician is if it is part of your job to have these conversations, then don't tell me I didn't get trained for it in school. They didn't have that training for me. It wasn't part of my college experience, my residency, my internship.
Right. And so I can't do it. I give up,
So I can't do it, except I'm going to have it. I'm going to do it, excuse my language, half-assed. And I'm going to document that the conversation was had. So I also get to bill for it. No, and this is a reality. I'm not picking on doctors, even though I'm kind of picking on them.
Yeah.
If this is part of your job, go and get the education out there. Make the time for it or stop having the conversations, because your patients do not have the luxury of your ignorance, your lack of education, your lack of dedication to doing it correctly.
Exactly.
They don't have time to wait for you to figure it out. Yeah.
Exactly. And it's part of your job. It's interesting. I gave a talk recently to a bunch of early medical learners, and somebody said something to the effect, one of the students said something to the effect of, well, do we really all have to do this? Like, does this have to be part of our work? Basically, we're saying, like, can't somebody else do this? And my response was, this is your job. And you can't say, I don't really like the kidney, so I'm just not going to learn kidney, and I'm going to be a doctor without knowing kidney, and someone else can do it. And this is just like that. This is part of your job, right. And you learn how to do it. And if you need more education, you can go to various places, including coming to me. This is part of why I train physicians in this exact thing. But it is a learnable skill for anybody, and it is crucially important. It's crucially important to reduce the suffering not only of the patient, but also of the family.
I think that's very good practical advice. I firmly believe in holding people responsible for these conversations. If I worked in hospice and palliative care, I've been in it almost 15 years now, but I didn't bother to study for my certification. I didn't bother to go out and get this increased education. I didn't join the professional groups, and I didn't go out and find a mentor who would work with me. Why do it if you're not going to do it well?
Yeah. And you know what I would add to that too is some physicians or clinicians maybe feel like, oh my God, I'm so busy. That's like one more thing I have to do. But I actually think that being skilled at these kinds of conversations is not only good for the patient, not only good for the family, but it's good for the clinician too. It makes us like our job better. Part of why people shy away from these kinds of conversations is because they're scared. They don't want to mess it up. They don't really feel comfortable. It makes them anxious. And so they have this kind of anxious energy around this patient now because they feel like someone has to do it, but I don't want to do it. And let me call palliative. I don't know. Whereas when you have real connection with people, when you go deep and you talk about deep, important things with people, you get a human-to-human connection that feeds the soul of the clinician too. So it's not just one more thing you have to know. It's actually a way to like your job better.
I have heard so many patients and families that came to hospice and said, we were told there was nothing else we could do. We're going to turn you over to hospice. So if you're an oncologist or a nephrologist or a neurologist, where maybe you've spent years taking care of a patient, watching their status decline and change. And then at a time when things are really getting dire, you say, well, I can't help you anymore. I'm just going to send you somewhere else. There's no satisfaction in dumping a patient off like that. Oh, and in addition, you have created this chasm where you've shoved a patient off the cliff and said, I can't help you anymore. You're out.
It's heartbreaking.
Oh, it is heartbreaking. And then hospice is supposed to receive this patient who has a feeling of being abandoned by somebody who's taken care of them for years. And we tell hospice patients, your attending physician, the physician that's been seeing you, can choose to stay on. Mm-hmm. More often than not, they choose not to because it's not their bailiwick. It's not their skill set. Yeah, and they don't feel comfortable with it. Well, that's an abrupt severing of a relationship and this trust that they've had from somebody they feel knows them very well. And I can't imagine the dissatisfaction, the lack of closure, for lack of a better word, that a physician or a clinician would feel knowing that this relationship that they've had, albeit it's a professional relationship, but it's ended so abruptly with no satisfying end. Half the time they don't even know what happens to the patient.
Right. And I really do think, of course, there's some exceptions. Some people are just jerks, but most people are not jerks. And I think mostly that happens because they don't know what to do. They feel uncomfortable and they don't know how. And that's actually why, for me, it's so important not only to teach families, but to teach clinicians, because that helps clinicians, but it also helps the families, because that feeling of abandonment is heartbreaking and it's totally unnecessary. And one of the things that you said in the very beginning, I think it happens so often. We need to teach doctors and other clinicians not to say this. There's nothing more we can do for you. No one should ever say those words, ever.
I
ever,
absolutely hate that.
But they don't know that. No, they heard it from their attending, right? When they were learning, it's mentoring. Nobody ever told them how to do it differently.
Right.
So instead, for example, they could say, of course, we will always treat you with aggressive care. Of course we will. When it's helpful to you, we'll treat you with aggressive, medically focused care. But right now, it looks like we don't have the medicines to make that helpful anymore. So we could hurt you with medically focused care, and we don't want to hurt you. So what we can do, though, is aggressive symptom-focused care, because we want you to feel as good as you possibly can feel every single day so that you can live your life. And, you told me about your grandkids, and you told me you play golf, and we want you to be able to have as much time with those things as possible. So we're going to aggressively treat that pain that you have, and treat your fatigue, and treat your nausea, so you can live your life.
I think there are words for all of these things if we'll only pause to learn them and to use them.
Exactly.
Oh, we could probably do the whole podcast on nothing but this. This is one of my pet peeves, because
I get it.
Working in hospice and receiving patients that have had these things said to them, it's so disheartening. It's so disheartening because it is something that we have perpetuated. We teach our people, the people that are coming after us, to talk to our patients like this.
Yeah, because no one knows any better. And it's funny that it's a multi-level problem, right? Part of the problem, it sounds silly, but is even the exams that the physicians take. So the step 1 exam and the step 2 exam, it doesn't include things like this. And so when students are learning, some nice attending will try to teach them about, well, let me teach you how to talk to patients. And they're like, yeah, but if I don't pass this exam, I can't be a doctor. So they want to know, like, what is on the exam? I can pass this exam so I can be a doctor.
Right.
If this were really prioritized, they'd have to learn it. It would be on their exams. And all of a sudden they would be way more motivated. And then doctors would teach doctors how to do it. And it would be more integrated, just like cardiology and neurology and, what are the drugs, all of that stuff. This is a learnable skill. It's not fluffy extra stuff. It is a learnable and crucial skill for taking care of people with serious illness, as you well know. I know I'm speaking to the converted.
No, I love that, though, because, it can't be fluff. It can't be extra, because every single one of the patients you're going to see is going to die.
And so
every
are you,
single one
by
of
the
them.
way.
Exactly. So every nurse has to go through labor and delivery.
Yeah.
In school, except not all of our patients are going to have babies.
Right.
Not
even 50%. Right.
Yes. So it doesn't make any sense. I'm a firm believer that in our formal required education, there should be a course or courses on death, dying, and end-of-life care.
I think so too. And I want to teach those courses. So go to teach clinicians how to do these things.
Absolutely.
Because what I know from the medical school in my area is they spend, a couple times with a hospice nurse.
Right. And that's pretty much it.
That's not, it's enough to know this is what hospice is. It's not nearly enough to gain the skills to actually be a skilled physician taking care of people who have serious illness. So it's not just hospice, right? You need to take care, if you're taking care of people who have heart disease, who have advanced neurologic disease, who are aging, who have dementia, who have cancer, any of these things, which many, many doctors will do, then these are skills that are crucial to have, period. They have to have them. It's not extra. These are crucial skills to have. So little by little, we're out there trying to teach the doctors how to do it better. But I think it's really
Every
important.
physician should hear this conversation. Absolutely.
I agree.
I hope you're enjoying this episode. We're going to pause for just a minute. My guest has more to share.
As hospice professionals, you understand the vital role that family caregivers play in ensuring quality end-of-life care. However, caregivers often feel unprepared and overwhelmed when the hospice staff isn't present. The Hospice Care Plan, A Path to Comfort, bridges this gap, equipping families with the knowledge and skills to provide exceptional care at home. Listen to hospice nurses Nancy Hireman and Brenda Kazire share why they created the Hospice Care Plan.
As nurses know, when you're out there providing care, you want to provide the best instruction to the entire the entire care circle. That would be the family, the hired caregivers, friends, neighbors, of course, the patient. And there is never enough time to teach what is really important. You certainly can't write down all the instructions when you're in the home. And so we realized we need a tool that can follow us out of the house, basically.
Yeah.
When families feel equipped to handle caregiving responsibilities, they can focus on cherishing time with their loved one. Implementing the hospice care plan as part of your hospice program ensures that your families have the tools to provide the necessary care between visits from your staff, increasing patient and caregiver satisfaction. Invest in this powerful resource to support your mission of providing quality end-of-life care. Visit thehospicecareplan.com for more information. The sponsor for this week's episode is Barbara Carnes Books, featuring the work of award-winning hospice RN educator Barbara Carnes. BK Books is proud to offer the End-of-Life Guidelines series, a compilation of 5 essential education booklets designed to support those caring for terminally ill loved ones. At the heart of this bundle is Gone From My Sight, affectionately known as the Hospice Blue Book, a timeless resource that has touched over 40 million lives. This bundle is more than just information. It's a lifeline for families navigating the difficult stages of the dying process, offering guidance for the last months, weeks, days, and hours. Trusted by end-of-life workers nationwide, the booklets provide direction for managing symptoms, explain the dying process, address pain medication use, and offer suggestions for moving forward with grief. The End-of-Life Guidelines series bundle from Barbara Carnes equips you with knowledge and tools to provide the best possible care. The bundle helps hospice agencies better educate patients and families, providing easy-to-understand guidance that can improve scores on their CAHPS satisfaction surveys. It's the ultimate caregiver's companion. Use it as part of your care plan today. Visit bkbooks.com today to order the End-of-Life Guidelines series to support your journey of compassionate caregiving.
Okay, so we're going to switch focus just a little bit because you are also a huge advocate for caregivers. Mm-hmm. Yes, vocal and very active, especially women. You have, I went into your website, you have a really, really great download that's on your website. And the first piece of guidance you offer is a little surprising. I don't know if you know what order they're listed in, but number 1 is do not blindly accept what you hear from your healthcare team. Mm-hmm. Why is that so important?
It is so important because as much as I adore healthcare in theory, our healthcare system is very imperfect. And it's imperfect for a whole lot of reasons. We could talk a whole hour about that too. But the truth is, let's talk about a few ways that it's imperfect. Doctors and nurses and other clinicians are stretched too thin, so they can make mistakes. They may not be filled up emotionally, physically, spiritually as people because they're kind of exhausted and burnt out. So they may not have all the empathy and care for you that they would want to have, right? Mm-hmm. Things get confused and they don't know you, like deeply know you. And so they don't know what is most important to you, patient or family. And so sometimes they may say things that are like, you should have this thing, this procedure, this chemo, this whatever, right, which sounds like a proclamation, like it's the only way to do it. But medicine is an art, not 100% science. And sometimes we try a thing and it doesn't work. Sometimes we try a thing, it helps. Sometimes we try a thing, it makes somebody worse. Sometimes they even die from our treatments. And so if you just let somebody else make a decision for you without knowing who you are, they may make a decision that is not in your best interest. Now, there are exceptions, of course. If you have a trauma, you have to go to the trauma surgeon, you do whatever they say. Right. If you have meningitis, you need antibiotics, you do whatever they say. But if you have a really advanced cancer and there's a chemotherapy that at best case scenario will prolong your life by 3 or 4 weeks, according to the studies, but will make you so sick and might even hurt you, don't let somebody else decide that for you, right? Should be working in concert as a team with your medical team, not in a hierarchical way where they just tell you what to do.
Right. It's across decision-making across all these disciplines. Do you think, Delia, that some of this is generational culture? So my mom is 91, and she will tell me, oh, the doctor said I need to do this. And I'm like, well, you don't have to. Clutch the pearls, gasping.
Right.
What do you mean? I'm like, so this is the best way I can describe it when I talk to her. I tell her, you're the coach, not the doctor. The doctor is the quarterback.
Yeah.
You're going to help him coordinate the plays, and he's going to run it on the field. But you are actually the decision maker. She does not get that. And it's so ingrained in her that that's probably never going to change. Do you think that mindset is changing, that people are feeling more empowered and autonomous in their decision making about their health care?
I do. Yet it's a nuanced answer, because what sometimes happens is the opposite extreme, which is also not ideal, which is people come in sort of ready to fight with the doctor.
Right,
like,
to argue.
I looked it up on the internet, and this is what the internet said. And so I don't want to do any of that stuff that you just said, and you have to do what I say.
Right.
That's also not ideal. So the ideal scenario really is we bring two pieces of information to talk about. One is, what is the medical reality? So what's happening here? Like, what disease do you have? What stage is it? What are the potential treatments? What are the benefits of those treatments? What are the risks of those treatments, with some specifics? So not like, oh, this could help you, because sometimes help you means it prolongs your life by a few weeks. You need to, that's what the doctor means. So, So part of it is the medical reality. Like, just tell me the facts here, because the doctor knows that. They bring that part. But then the whole other equally important part is, who is that person? What are their values? What are their goals? What's important to them? Some people feel like, I want to live every single second on this earth that I can live, no matter what state I'm in. Okay, you get to say that. You get to pick that. So you got to tell that to the doctor, because the decisions might be different than if someone said, this is more how I feel from just myself. If I can recognize people and communicate with people, I would like to still be here, and let's do aggressive things to see if that's possible. But if I am in a persistent vegetative state and I'm never going to wake up again, I don't need to prolong my life in that situation. And because that's my values and my goals. So how could that doctor, if they didn't know that about me, which of those two people I am, how could they possibly make a decision for me? Right? But yet, how can I make a decision if I don't know the medical reality? So if I come in like, I want this chemo, I read about it, and the doctor knows, well, gosh, the studies showed that in people that fit your profile, the more people died than were helped. That's information that they bring. So that combo of the medical information and the goals and values of the person, then you work together, patient and doctor, family and medical team, to work those two things together to make a decision that makes sense for the person.
Yeah. It's counterproductive to come into your healthcare provider, your clinician, your team, your doctor, and say, this is what I already know and this is what I want. If you're but if you're coming to a professional and they're the expert, their input is vital.
Yep.
Right? Otherwise, why bother? Why bother?
Yeah. I love how you said that.
There's definitely balance.
Everybody's input is vital, right? So the doctor's input is vital about the medical team, the medical info, and the patient's input is vital about who they are and what's important to them and what they're hoping to get.
Right. And the caregiver or the advocate, the 100%. Person who might be the decision maker or who will become the decision maker, all of that has to be added in. I think it's quite a dance, and we're not always in step very well to do that.
Yeah. Can I bring up one thing I think is so important? There's something called the dignity question. It didn't come from me. Harvey Chachanoff is the MD, PhD, is a person who champions this work.
Yes.
And the dignity question is, what do I need to know about you as a person to take the best care of you possible? What do I need to know about you as a person to take the best care of you possible? Imagine if every doctor dealing with a patient who was dealing with some serious illness started with that.
Yeah. Who are you? What do I need to know about you? What do you want me to know about who you are?
Right?
Yeah. Basically what that says is, I'm not just looking at your kidney functions. I want to know who you are as a person. Yeah, it's about whole person care. It's about your life goals. I did a post the other day on social media that said, whose goal is this anyway?
Yeah, exactly.
Yeah. Is it the provider? Is it the healthcare team? Or is it actually the patient's goal? Or even the caregiver's goal? Because caregivers sometimes weigh in pretty heavily. So what other tips do you offer to caregivers? Because you got some great stuff on your downloads.
There's so many.
Pick your top 2.
Okay, let me pick my top 2. They're related. So one of the things, I don't even know if it's in that download, but I think it's so important, so I'm going to share it. One of the things that I think is so important is to avoid toxic positivity, but make space for gratitude. And here's what I mean. So toxic positivity is this. This comes up in serious illness all the time. The patient will maybe be coming to some awareness, and say, well, I don't know if the chemo is going to work, or I don't know if I'll be here next Christmas. And the family will jump in and say, don't say that. You can't say that. You have to think positively. Everything's going to be fine. And they're coming from love when they do that. They're not trying to be unsupportive. But what that does to the patient is it gives them the message, we don't talk about that stuff here. Right. Your fears are not welcome here.
Right. It's isolating. Right? It's isolating for the patient.
Totally isolating, because it's not like you saying that made their thought go away. It's now they're all alone with it. Right? They're all alone with it. And so that is not great. But there is a tool that I use for myself probably every single day that I share all the time, I think is so important, which is this sentence. I don't like blank, but at least blank. So I don't like that the chemo seems like it may not be working, but at least I have really great doctors. Or I don't like that I have to have surgery, but at least it's the summertime and it's beautiful outside the window. And they don't even have to be connected. I don't like that I have to go to this doctor's appointment, but at least I got a great parking space. Or even I don't like that I have to take this medicine, but at least my dog is adorable. They don't have to be connected. What it does is it makes space for two opposing things, something yucky and something a little more positive. Doing that all the time just trains you. We don't shut out the negative. We're like, yeah, that sucks. But at least, and like we learn to turn our head a little to the side to look for flowers in the poop is what I say, to look for something positive, even in a yucky situation.
Yeah, it's gratitude. It's finding something, and it doesn't have to be anything big.
No, could be a sandwich. I had a great sandwich today, right? I met
a parking space. A parking space is a big deal when you have to walk into a doctor's appointment. Right. So that's what is referred to as realistic optimism, acknowledging the crappy stuff that you're going through, that you're dealing with, and then finding the flip side of it or something positive inside the situation as well, which as human beings, we thrive with balance like that.
Yeah.
Right? If you dwell on the negative, you end up with depression and anxiety, which is inherent to a lot of these serious illnesses anyway.
Yeah.
The circumstances bring them. And then on the other side, when you have the toxic positivity, it's denial, it's postponement, it's conversations that never happen.
And it's isolating for families. It sends everyone to their own corner just when it's most important for them to be together.
When patients or someone with a serious illness wants to talk about these things and say, I have things I want to talk to you about my funeral. Oh, no, it's too soon to talk about that. We can't talk about that. And shuts that down. That conversation may never happen.
Correct.
And that person may not feel safe and secure that they could talk to this loved one or whoever they tried to confide in. Can you imagine if you had a serious illness or you were looking at a terminal diagnosis and you needed to talk about that because it is part of processing for a lot of people, processing their grief and preparing themselves emotionally and psychologically for a death. And then the family says, well, we don't want you to talk about that. It's too hard for us to hear it.
It happens all the time. And what you just said is exactly what they're communicating. They think they're being loving when they say, oh, no, you got to be positive. It's going to be okay.
Right.
But what they're communicating is exactly what you said, that we don't talk about that here because I can't handle it.
Right.
And it is inadvertently unkind to their loved one. And they don't mean to be unkind and unsupportive, but it is in fact unkind and unsupportive. And that's why I think it's so important to talk about it. That's why I brought that up. Because when people say gratitude, yes, of course, gratitude is amazing, but sometimes it gets misinterpreted as everything's fine. We're just going to say everything's fine, which is not healthy. And that's toxic positivity and is really wounding to people at their sometimes the last times that they're going to be able to talk to someone on this planet. And we don't want to isolate people. So a way better way to approach if someone says, I want to talk about something, or, what if I don't make it to Thanksgiving? Tell me more about that.
Right.
Just say that. Tell me more. Tell me more about that.
Tell me what you're thinking about that.
Yeah.
What a gift to be able to give to somebody just to listen. We're not saying it's easy. Okay.
No.
Because if it's someone that you care about,
it's not easy.
No, to hear them talk about their own feelings and grief and the plans, the dreams that may not come to fulfillment and what they want to pass on to someone else. Yeah. That amplifies our grief. And again, it's the both and. The grief and the joy both at the same time. My grandmother sharing this beautiful memory with me, or a recipe, or my dad is telling me, I have things that I did that I need to share with you, and I want you to know where the coupon drawer is, that sort of things. To be able to share that in and of itself is actually a great gift.
Yes, it is.
It's just hard to see it in the moment because it hurts so much.
Yeah.
Yeah, that's a great tip. So you're such an advocate for caregivers, but you also advocate for clinicians. And on behalf of nurses, hospice nurses, I say thank you for that voice. It's so important. Tell me why you think that care for the clinical caregiver is so important.
Oh boy, it is so important because this is such crucial and amazing work. And even though we've been talking about clinicians who don't do a perfect job of it, all of them try, and some of them do an amazing job at caring for families at a really difficult time. And when you do that, you can become fatigued yourself. You can get compassion fatigue. So you're giving out. And these are often just kind of naturally empathetic, kind people who may not have a ton of boundaries. And so they may give so much that they get empty, they get depleted. And that is not good for anybody. It's not good for the clinician, of course, because they get burnt out. They might even leave nursing or medicine because they're so wiped out. It can impact negatively not only their own well-being, but their kids, their loved ones, their spouse, if they have one, the dog, the people who are in their life, because when we are burnt out, we're crabbier, we're cranky, our empathy goes down. We can't be there as much for the other people in our life. We're not as fun. Our energy is different. We're not as joyful. And none of that is good for anybody, including their patients, because you don't want a burned out nurse or burned out doctor.
Yes.
Right? You can feel it when they walk into the room if somebody's energy is dark or like edgy or
stressed,
empty, stressed, if they're depleted. That nurse walks in the room and you're like, ooh, no, thank you.
Oh, yeah, it's almost like a vibe. You can feel it.
Right, you can. So it's not good for anyone. It's not good for the nurse or doctor themselves, their family, or the patient. So I really do believe that part of showing up for patients, so part of being a great nurse for seriously ill people or a great doctor for seriously ill people is filling up your own cup first. It's part of your job. Because if you don't do that, you will not be as good for your patients. And you shouldn't do anything that makes you be not as good for your patients.
Say that again. This is part of your
job. It's part of your job to take care of yourself, fill up your own cup so that you retain your empathy, retain your healing presence so that you can be good at your work. Otherwise, you're not good at your work. And you wouldn't do something else that makes you not good at your work. You wouldn't not read articles or not study because you want to be good at your work. This is part of your job, to fill yourself up, take care of your own well-being so you can show up with the healing presence that your patients deserve.
Oh, I think we don't think about it that way. I think that clinicians view that care of themselves as a luxury, as the fluff.
Yep, it's not. I agree. They think that, but they're wrong.
And it's no longer the manicure, pedicure, take a 2-week vacation. We're talking about, do you take a deep breath before you enter a patient's room?
100%.
Do you phone a friend after a really bad conversation or a death that really affected you and say, I need you to listen to me for 8 minutes?
Right. Exactly.
Yeah.
And that's why I use this model of a cup. You could use a gas tank if you want, but a cup being full, because it's not about whether or not you do yoga or whether or not you go to the gym. What fills or empties your cup is different for each one of us. So you could go to yoga, but spend all this time being anxious and have your untreated depression and be angry with everybody and eat a ton of junk food. That's all emptying your cup. You're still going to be depleted. Yoga's not fixing that. Right. So it's really about, we all know, we can tell, right? If you say, are you filled up or are you depleted? We can tell. And our goal is to check in with ourselves all the time. I don't know, every day, every week at the most, or the least, check in with ourselves. Where am I? If I'm feeling depleted, what fills my cup and what empties it? So let me do a little more of what fills it and a little less of what empties it. Because if I'm starting to get depleted, I am not showing up for myself, but I'm also not showing up for my patients. And that's not part of being a good nurse or doctor. We need to show up with our best healing presence. And in order to do that, we have to fill up our own cup. It's fundamental. It's not a luxury.
Oh, I like that. I like that. What I tell colleagues is, you are more important than the work. Mm-hmm. You are more important than the work. And I truly think that that's real. We're understaffed. We know with the silver tsunami population that's aging into needing end-of-life care, there's a lot of them out there, and there are not enough clinicians to handle it. So short staffing is not going away. Yeah. And, we're horrible mentors and models when we let ourselves be burned out and burned down.
Correct. I use that sometimes in counseling other people, other clinicians, is think about what you're teaching the younger doctors. Do you want what are you teaching even your kids? Do you want them to see that that's how they should behave, that they should give with no recognition of what their needs are until they fall to the ground? Is that a model that you would teach to a younger person? And when you put it that way, they're always like, oh, no, I would tell them they should take care of themselves. But of course, it doesn't work to say, do what I say and not what I do. They're watching you.
Well, and I can only speak for nurses, but, we've been pretty notoriously bad at that. Yeah. When I worked home health years ago, I would counsel a diabetic patient or a cardio patient, and I would say, here's a low-fat diet, et cetera, et cetera. And then I would get in the car, stop at Burger King, have a Coke and a hamburger on my way to my next patient. Right. And nurses struggle with depression and obesity and substance abuse. We're smoking a cigarette in between patients, going from one COPD patient to another.
Doctors too.
Yeah, we're not any better. And I sat next to a hospice physician that would talk about, patients during the interdisciplinary team meeting and patients that needed to stop smoking because, in end-of-life care, for my listeners that don't know too much about this, we don't force people to give up whatever substance use they might be dealing with, even at the end of their lives. So if you have a nicotine addiction and you need to smoke, you go right ahead. Take your oxygen off, go out to where you're safe so you don't endanger 100%. Anybody. Yep. Have a cigarette. We're fine with that. And I remember this hospice doc sitting next to me and just sort of having a conniption fit over a patient that was insisting on smoking. End of life. And this doctor reeked of cigarette smoke. And I'm like, dude, I know you had a cigarette before you walked in here.
Hypocrite much? Right.
Yeah. And so we're, okay, so let's just level the playing field. We happen to be the same humans. We just
100%.
work in this particular field, right? We are the
Correct.
patients.
We are. Of course we are.
will be the patients. Our families are just as dysfunctional as everybody else's.
Yes, they are.
Right? This will be us.
Yep.
So, Delia, let's dig really deep, if you don't mind getting a little personal with me.
Sure.
How has doing this work changed you?
I think that it has made me appreciate every day more. And I know that sounds a little cliche, but it's really the truth. People think, oh, palliative care must be so depressing. But here's what I saw. I used to work in hospice more specifically with hospice patients, was a lot of them were kind of happy. They were not happy that they had an end stage illness, but, facing their own mortality, they were like, well, I don't like that guy. I'm not going to talk to him anymore. And what I really want to do is sit in my garden. So I'm going to sit in my garden and I'm not going to do stupid things that I don't like. Like, I'm not wasting the time I have doing stuff I don't like. And they kind of reordered their life to do things that they liked. And that turns out makes you happier. And so it really has struck me the whole time that I've been engaged with this idea that, how about if I learn that before I get cancer or whatever I'm going to get?
Right.
Can we learn that? Why do we have to wait till we're on hospice to learn that? Like, can't we learn that now? And I'm not perfect at it, of course, but I constantly remind myself, there's no guarantees. Who knows how long I have? And rather than going to bed and pulling the covers over my head with that idea, I feel like, well, let me do everything I can to enjoy my life right now. And I really appreciate that perspective, because that is literally all we have is right now. Because who knows who goes first? We all drive cars, right? It could happen anytime. We don't know. We have no idea. So rather than worrying about it, let's really try to focus on the now. And when I start to catastrophize, I can often catch myself and bring myself back to like, yeah, but the birds are outside and my dog is over here and I'm going to go have lunch. And like, what am I doing right now? And right now it's pretty okay. So I think it has improved that skill for me, which was a good thing, because I think my inclination was to be more of a negative thinker. And it has made that better.
If you could go back and give some advice to your 20-year-old self, what would you tell her?
I would tell her that life is windy. It's a windy road, and it's okay. And you don't have to know where you're going from the beginning. I use this thing for myself, and I've taught this to my patients many times too, this whole warmer, colder thing. When I was a kid, we used to play this game where somebody would hide something, and then you start wandering around the room and they say warmer, warmer, colder, colder, depending on if you're getting closer to it or not. And I use that for myself. So often in my life, I don't know exactly what I'm supposed to be doing next, but I know if something comes up for me, if it's warmer or colder, right? Like if somebody said, do you want to do family medicine again and you will see 40 patients a day? That is colder. No, like that's cold. Do I know exactly what I'm supposed to be doing next? Maybe not, but I know if something feels warmer. So if someone says, oh, well, hey, do you want to start a podcast where you're going to teach clinicians about integrative palliative medicine? I don't exactly know where it's going to bring you, but you would share what you know, you would interview cool people, and you would teach people stuff. Yeah, that's warmer. That's definitely warmer. Right. And so my feeling is if you keep going to the warmer things, it may be a little twisty, but you will get to a place that makes you happy.
I love that advice. So how can my listeners find you and listen to the podcast that you do?
For sure. So my website is integrativepalliative.com, integrativepalliative.com. And the podcast is the Integrative Palliative Podcast, which is on Apple and Spotify and all the places that you listen to your podcasts. So I really do encourage people to go check it out. And then also I do have a new book, which is called Coping Courageously, a heart-centered guide for navigating a loved one's illness without losing yourself, which I have gotten really wonderful responses about from caregivers, from family caregivers.
Awesome.
So come reach out. Send me an email through the website. I'd love to connect with people. I really love talking to people for whom this kind of stuff resonates.
Thank you for being such an advocate for all of us humans, those who take care of other people in a healthcare system and those who need the care. You're wonderful. Thank you so much, Delia.
Thank you so much for having me. I loved our conversation.
Be sure to catch the next episode of the Heart of Hospice podcast. You can find more episodes on theheartofhospice.com, and don't forget to follow us on your favorite podcast platform. You can connect with the Heart of Hospice on Facebook and Instagram and send your questions or comments by email to helen@theheartofhospice.com. And remember, no matter who you are or where you are in your hospice journey, you are the heart of hospice.
This is the Whole Care Network. Helping you tell your story one podcast at a time.